accompanied with headache. Vertebrobacillar migraine, sir.
Okay. Posterior circulation signs you are talking about.
Yes, sir. Yes. Fine.
Diplopia, all the dangerous diplopias, dysarthrias, reduction in consciousness, these things. All the dangerous Ds. Okay.
Thank you so much.
Yeah, thank you, sir. Yes, Dr. Vishwanath.
Sir, good afternoon.
Yes, sir.
During the discussion, there was a mention of visually induced vertigo and motion sickness.
Mm-hmm.
So, can you differentiate it on the basis of what the patient is telling us during history?
No, see, what was the point that I was making? Visually induced vertigo?
Both are different. One set is visually induced vertigo and motion sickness. Both are basically different.
I think rather than motion sickness, I must have told head motion dizziness.
Head motion. So, but for a visually induced
dizziness, visually induced vertigo is what happens when the scene is moving.
Okay.
Okay, the person need not be moving.
So the head will be static. The surrounding
will be static. Head will be static. So in front of them, if there is a train moving, fast moving train, they feel dizzy. That is visually induced dizziness or vertigo. Then head motion dizziness is where head motion vertigo or head motion dizziness. Here is the point of when we go to the vertigo definition. You can go through the vertigo definition again. Okay, there are two parts to the definition. Part number 1 of the vertigo definition is a sensation of motion when the person is not moving. Is that right?
Yes.
And that is what we have been taught all these years. But then there is a part 2 to the definition. Okay. The part 2 to the definition is, I think Dr. Sharafin, the car is too warm, I think. No, it's okay. I was thinking you opened the window. I thought the car is too warm inside there. So there are two things there. Okay, one is that part. When you are not moving, you feel that you are moving. The second part is when you are moving, but you feel either the direction or the speed of the movement is altered. Okay. So when we talk about head motion dizziness or head motion vertigo, this is what happens. There are people, especially with migraine, who present with this. When they are suddenly moving, they feel. So they may move to the side, but they feel that they are moving much faster than what they are moving. Or they may move like this, but they feel like they are going to fall back. See, what happens here is either the velocity is changed or the direction is changed. It is not when the person is not moving, he is feeling a sensation of moving. It is person is moving, but the velocity or direction is changed. So when you look at the definition of vertigo, both these components you will have to take into account. The component number 1 is when the person is not moving, the person feels like moving. That is also vertigo. But when the person is actually moving in real, then if the direction is altered or the speed is altered, even that is called as vertigo. Okay, sir?
Right.
So I think your both terminology thing is clear. Okay, sir? Yeah. Yes, Dr. Spurti.
Hello.
Yes, ma'am.
Sir, in this directional pulsion and unsteadiness, you mentioned that if it is more than 2 directions, then it will... how will you differentiate? So you said that it can be in more than 2 directions also.
See, what happens here is, okay, directional pulsion is always to one side. Okay, patient will always tell. Okay, there are patients with thalamic problems. It's always clearly to one side. There is a CP angle lesion. For example, there's a huge arachnoid cyst pressing on the vestibular nerves. In this case, what will happen is the person feels always to one side. The push is to one side. That is unilateral vestibular stimulation. Either it is with person with vestibular neuritis. They will always tell, I keep falling to one side. Compare that with a person with bilateral vestibulopathy. Okay, in a person with peripheral neuropathy. They don't have a directional specificity. They keep falling, they keep moving in any direction. Sometimes it feels like this, sometimes it feels like 10 times you repeat, you can't really tell which side the person is having. So that kind of a thing should be called as unsteadiness. Whereas when there is a directionality, always, some people always have a retropulsive movement. Okay. So then you have to call it as directional pulsion. Right, left, forward pulsion, backward pulsion, whatever. It can be a diagonal pulsion, whatever. Okay, ma'am?
Sir, yes, sir, but then you said that sometimes they can have both. Like they can have like two directions in which they have a preponderance to fall in the directional pulsion.
If there is two specific directions, I would always to front or to back, only front and back, or right and forward, always either sometimes right, sometimes, still call it as directional pulsion. When there is no direction specificity at all, each and every time it keep, but it is generally unsteady. So that should be called as unsteadiness. Okay. Even if it so happens that you have a patient who has two directions, call it as directional pulsion and write two directions rather than calling it as unsteadiness. Okay.
Yes. Thanks.
Yes, ma'am. Yes, Dr. Mukundan.
Good afternoon, sir. Sir,
Yes, sir.
I wanted to ask how much time should you spend on history in patient?
See, what happens is, what we are right now doing is a little different. We are putting the basis to put a strong foundation for something that is going to come in the hands-on session. And when you finish the hands-on session, you will be so confident that most patients you will not need, for reaching a diagnosis, you will not need more than 5 minutes. In less than 5 minutes, you will be reaching a conclusion in almost every patient, except in the difficult cases, okay, where you want to take a lot of history. You would have reached a diagnosis. But then, for the sake of completion, we do a lot of other works, okay. Like for example, let me take the example of a fall. Somebody comes to you and says that I had a fall. Like this, 8 groups are there, I will come to all those things. First question you are going to determine in your mind when the patient has started opening the mouth and started describing the fall is, this person lost consciousness or did not lost consciousness, number one. And person thinks that, okay, the person actually lost consciousness, done matter, okay, lost consciousness. The moment patient has lost consciousness, only 2 things come in your mind most of the time, two most common diagnoses. Seizure, syncope. 2 additional things will be there. Okay, that's okay. That is something called as a syncopal migraine, and another thing is hysteria. Okay, hysterical psychosis, conversion disorder. Okay, 4 differential diagnoses. That's all that will come in our mind. All other things after so many years, there is nothing additional that I've added to that particular fall with loss of consciousness. Then I will ask the question, okay, 1, 2, 3. Okay, sometimes it is difficult, sometimes it is. But my directed question will be there. Okay. If the patient, simply by the description tells, one of my patient came like this. One question happened, second question I knew that he had lost consciousness. Third thing he started telling, before this happens, I feel like, now I'm sitting next to you. I feel like this has happened before. Lost consciousness, number one. And person thinks that, okay, the person actually...
It is more than 2 directions, then it can... how will you differentiate? So you said that it can be in more than 2 directions also.
See, what happens here is, okay, directional pulsion is always to one side. Okay, patient will always tell, okay, there are patients with thalamic problems. It's always clearly to one side. There is a CP angle lesion. For example, there's a huge arachnoid cyst pressing on the vestibular nerves. In this case, what will happen is the person feels always to one side. The push is to one side. That is unilateral vestibular stimulation. Either it is a person with vestibular neuritis. They will always tell, I keep falling to one side. Compare that with a person with bilateral vestibulopathy. Okay, in a person with peripheral neuropathy. They don't have a directional specificity. They keep falling, they keep moving in any direction. Sometimes it feels like this, sometimes it feels like 10 times you repeat, you can't really tell which side the person is having. So that kind of a thing should be called as unsteadiness. Whereas when there is a directionality, always, some people always have a retropulsive movement. Okay, so then you have to call it as directional pulsion. Right, left, forward pulsion, backward pulsion, whatever. It can be a diagonal pulsion, whatever. Okay, ma'am?
Sir, yes, sir, but then you said that sometimes they can have both. Like they can have like 2 directions in which they have a preponderance to fall in the
If there
directional
are
pulsion?
if there is two specific directions, I would always to front or to back, only front and back, or
Okay.
right and forward, always either sometimes right, sometimes, still call it as directional pulsion. When there is no direction specificity at all, each and every time it keep, but it is generally unsteady. So that should be called as unsteadiness. Okay.
Okay.
Even if it so happens that you have a patient who has two directions, call it as directional pulsion and write two directions rather than
Okay.
calling it as unsteadiness. Okay.
Yes, thanks.
Yes, ma'am. Yes, Dr. Mukundan.
Good afternoon, sir. Sir,
Yes, sir.
I wanted to ask how much time should you spend on history in a patient?
See, what happens is, what we are right now doing is a little different. We are putting the basis to put a strong foundation for something that is going to come in the hands-on session. And when you finish the hands-on session, you will be so confident that most patients you will not need, for reaching a diagnosis, you will not need more than 5 minutes. In less than 5 minutes, you will be reaching a conclusion in almost every patient, except in the difficult cases, okay, where you want to take a lot of history. You would have reached a diagnosis. But then, for the sake of completion, we do a lot of other works, okay. Like, for example, let me take the example of a fall. Somebody comes to you and says that I had a fall. Like this, 8 groups are there, I will come to all those things. First question you are going to determine in your mind when the patient has started opening the mouth and started describing the fall is, this person lost consciousness or is not lost consciousness, number one. And person thinks that, okay, the person actually lost consciousness, done matter, okay, lost consciousness. The moment patient has lost consciousness, only 2 things come in your mind most of the time, two most common diagnoses. Seizure, syncope. 2 additional things will be there. Okay, that's okay. That is something called as a syncopal migraine, and another thing is hysteria. Okay, hysterical psychosis, conversion disorder. Okay, 4 differential diagnoses. That's all that will come in our mind. All other things after so many years, there is nothing additional that I have added to that particular fall with loss of consciousness. Then I will ask the question, okay, 1, 2, 3. Okay, sometimes it is difficult, sometimes it is. But my directed question will be there. Okay. If the patient simply by the description tells one of my patient came like this. One question happened, second question I knew that he had lost consciousness. Third thing he started telling, before this happens, I feel like now I am sitting next to you. I feel like this has happened before. That's a deja vu phenomenon. Matter closed. There only I close this thing. It is a temporal lobe epilepsy, boss. I write a neurology opinion. And then afterwards I spend time there is a thrill in taking history of these patients. For that we spend a lot of time. But then at that stage our diagnosis is done.
Yeah.
Somebody tells that I had headache and then I fell. I'll put it as a syncope. Somebody tells I fell. After that for half an hour I used to have a severe headache. I'll put it as seizure. Waking up and having headache goes in favor of seizure. Having a headache and then falling goes in favor of a syncopal migraine. Okay, like that. Another person comes and tells, again, same example of fall. And then when the person, I was driving a bike and then I suddenly felt something pulled me to the ground and then I fell and all those things. He will come and tell. There only he is so clearly telling something pulled him to the ground, all those things. Question number 1, by his description only answered, he did not lose consciousness. The moment he did not lose consciousness, I want to ask whether there is energy, there is no energy. He is telling there is energy. So the moment there is energy, it becomes a vestibular related fall. Now after vestibular related fall, then I will have 4 differential diagnoses in my mind. Is it vestibular paroxysmia? Is it vestibular migraine? Is it Tumarkin's crisis of Meniere's disease? Is it BPPV? And right now I will just proceed with the examination, rule out PPPV, take further questions about migraine to rule out it is not migraine, or circumstances of the fall. Before that 1-2 days you missed sleep, you were stressed out, those things. There ends the matter. So this is how things progress. So it is not like I am not in favor of those elaborate history sheets where we used to capture for 45 minutes and then where we were as intelligent as we were when we began. It is not like that. Okay, there is a structure. What we are now doing is all of us are agreeing on a common terminology. For all of us, unsteadiness means unsteadiness. Lateral pulsion means lateral pulsion. Okay. So we all of us are agreeing on a particular type of terminology. But when you come there, I had headache and then I fell. I'll put it as a syncope. Somebody tells I fell, after that for half an hour I used to have a severe headache. I'll put it as seizure. Waking up and having headache goes in favor of seizure. Having a headache and then falling goes in favor of a syncopal migraine. Okay, like that. Another person comes and tells again same example of fall. And then when the person, I was driving a bike and then I suddenly felt something pulled me to the ground and then I fell and all those things. He will come and tell me. There only he is so clearly telling something pulled him to the ground, all those things. Question number 1, by his description only answered, he did not lose consciousness. The moment he did not lose consciousness, I want to ask whether there is energy, there is no energy. He is telling there is energy. So the moment there is energy, it becomes a vestibular related fall. Now after vestibular related fall, then I will have 4 differential diagnoses in my mind. Is it vestibular paroxysmia? Is it vestibular migraine? Is it Tumarkin's crisis of Meniere's disease? Is it DPP? And right now I will just proceed with the examination, rule out PPPV, take further questions about migraine to rule out it is not migraine, or circumstances of the fall. Before that 1-2 days you missed sleep, you are stressed out, those things. There ends the matter. So this is how things progress. So it is not like I am not in favor of those elaborate history sheets where we used to capture for 45 minutes and then where we were as intelligent as we were when we began. It is not like that. Okay, there is a structure. What we are now doing is all of us are agreeing on a common terminology. For all of us, unsteadiness means unsteadiness. Lateral pulsion means lateral pulsion. Okay. So all of us are agreeing on a particular type of terminology. But when you come there, you will go through one full session of how to reach a conclusion in each of these patients, and after that, lots and lots of patients, if they are vestibular, you will be able to reach a diagnosis or get a thing as to how to proceed from there. Okay, either reach a diagnosis or how to proceed from there, you will have a clear idea. As long as I am putting the caveat, as long as they are vestibular, 50% of the patient who come to us with balance related complaints actually don't have vestibular complaints. Okay, but I am not telling lose hope. For them also we will be reaching a clear cut, in some patients the diagnosis, in some patients the way forward. Okay, thanks. Question? Any more questions? Dr. Nigel, I can see you are talking, but your mic is muted.
Yeah, sir. Sorry. Sir, I just have a doubt. In the criteria for diagnosis, there's like 5 episodes in vestibular migraine. They said 5 episodes. So when we say 5 episodes, it can be like, there's no time frame, right? It can be like...
It can be over 25 years, no problem.
It can be any time in the patient's life?
Absolutely. It can be over 25 years. It doesn't matter.
And sir, this is actually, I don't know why this doubt. I have this doubt only now.
You can ask.
After that picture of yours in that superior semicircular canal dehiscence, that diagram, why is it that the fluids in the semicircular canal is not set into motion when there is no dehiscence? Like normally when
there is no dehiscence, it is set into motion by head movement.
No, when the
head movement only.
Why not when the foot plate induces?
When the foot plate moves. Okay, that's a very nice question. In fact, I met an Israeli person who had actually made some rat models where he actually induced. He created dehiscences to study the fluid flow and all that. Okay. See, what happens here is the way the cochlear compartment is there and the vestibular compartment is there. There is a very nice feature. What is the other name for superior canal dehiscence, lateral canal dehiscence, all these things put together called large vestibular aqueduct syndrome?
Third
window phenomenon. Okay. So the idea of windows, 2 windows in the inner ear, is to make sure that the energy dissipation happens only in a certain compartment and it does not happen in the other compartment. Okay. I think there was something that was shared by Chandrakant Vishwakarma had shared something last week. and that was shared to everybody. I think on WhatsApp or something it must have been broadcast. Abhishek must have done that. Otherwise, I can get it done to everybody. Okay. So about that. Now when there is no third window, the energy does not dissipate in that particular direction. But when there is a mobile window, there is another route through which it can escape, and that is why the fluids are set into motion. Okay. This is like more into hydraulics and hydraulic principles and these things. Have you played with the hydraulic toy? Huh?
No.
You're not played with the hydraulic toy. Okay, I have a hydraulic toy. I'll see if I can do it. So whichever side there is yielding, on that side it gets pushed. Before that there was bone covering. It is not yielding. So towards that side it doesn't get pushed. Though the pressure is same on all the sides. Okay, sir?
Okay, sir.
Okay. It is more like that is why. So there is a mobile window, so towards that when there is no mobile window, it doesn't. The stapes foot plate movement does not cause that.
Okay, sir.
Okay, it doesn't yield on that side. Whichever side yields, only that side it goes.
Okay. Okay, sir.
Yeah.
Hello, sir.
Yes, Dr. Teja.
Hello.
Yes, ma'am, I can hear you.
Sir, I just wanted to know, is there any particular age at which migraine can occur? As in, it starts at early, like say 20s?
Migraine is a disease which is seen, whose manifestations are seen from the neonatal age onwards.
Okay.
Okay, so in those...
So is it possible that...
Yes, ma'am. Yes,
so
ma'am.
is it possible that a person who is as old as 45 years can develop migraine?
See, if a person who is 40, this is a wonderful, wonderful question. And please note down all of you this one thing. It's a beautiful question, so it will give you a very beautiful clinical point. If somebody all of a sudden develops at 45 degrees, at 45 years of age, first time onset migraine, then please don't take it as migraine. Okay, please don't take it as migraine. It is almost always atherosclerotic vascular disease or some other vascular problem which presents as a de novo migraine in a 45-year-old person. If somebody at 45 years old, I used to work closely with a neurologist who specializes in stroke, and he used to tell me any de novo migraine in a person above 40, you should consider it as atherosclerotic vascular disease and not as migraine.
But then
Okay, ma'am.
So from neonatal age up till 40, we can consider it to be diagnosed as migraine?
It is like, see what happens, maximum at some point of time before they are 30, they would have had an episode. Okay, they would have had an episode.
Yes, sir.
See, sometimes they will not tell, but then if you ask, they will tell. If you spend, some people come, there are doctors who come to me for consultation, and what they tell is like, the best thing that they like is that this history part, okay, where they are encouraged to start recollecting from their school days. And when they start recollecting from there,
Yes.
and then
Yes, correct.
they will start telling, yes, I had. Once I actually slept in the school, when I was in 6th grade, one full period I could not concentrate, I was sleeping something. Something would have happened. Somebody, sir, in the school on one
Yes,
particular day, there was a drill going on. On that day, I had very, very difficulty in, okay, I could not tolerate those sounds on that particular day. Like this, they will tell something. Okay, but most of the time, before 30, they would have had.
Correct.
Okay.
Okay, sir. Yes.
Thank you, ma'am.
Thank you.
Any more questions? So please please remember that this is a very, very critical point what madam asked about at 40, above 40, somebody provoke headaches.
Yes.
Okay, can itself provoke headaches. So therefore, when we see and when we evaluate the patient, we get the typical nystagmus. Irrespective of the headache being there, still we should actually treat that nystagmus. Means what that nystagmus tells, the canal that nystagmus tells, we should go ahead and treat. That is one thing. Migraine again predisposes patients to BPPV. That is one more thing that happens. BPPV can provoke attacks of headache, migraine headache. Migraine can predispose people to BPPV. So we have to have a multi-pronged approach to treat this patient. We are going to treat the BPPV also with the positional maneuvers. We are going to treat the migraines also. Then there is one more group of patients which are going to come. And this is the calendar pattern that has to be remembered by all of us. This is a person who will come and tell, I get this positional vertigo. Whenever I change position, when I look down, when I look up, when I turn right, when I turn left, I get it. It lasts for 3 days, it lasts for 4 days, it lasts for 5 days, it lasts for a week. Then it just goes off. Just to reappear after a month, after 1.5 months. Again, it is same, 3 days, 4 days or 1 week it is there. And then on its own it goes off. This is clear-cut migrainous positional vertigo. You notice the calendar pattern? Okay, somebody gets for 3 days, 4 days, 5 days. And these are patients who will not respond to repositioning maneuvers. If the person has responded to repositioning maneuvers and still getting headache, you can take it as either migraine has induced the BPPV. That is one. Other possibility is the BPPV has triggered the migraine. Okay, even when you go for that matter, not just BPPV, when you look at Meniere's disease, the first description of Meniere's disease by Meniere himself in his paper, he tells there are a lot of migraine features in these patients. So, the one possibility is that migraine Meniere's, that there is a part of a continuum. The other possibility is that vestibular stimulation itself is triggering the migraine headache. The proof for this comes from my office. Our boys go around the country giving demonstrations and all those things. One of our boys is a migrainer. So, during the time of giving a demonstration, he underwent a caloric test. Post-caloric test, such a huge migraine was provoked in him that he was vomiting. He had a huge headache, and almost for 1 day, he was little, okay, in fact, so like that it happens. So, migraines can be triggered by intense vestibular stimulation. So, what is the take-home point of all these things? They can be together. Treat both of them. Treat both of them. Also remember the calendar pattern. Okay. How do you make a migrainous positional vertigo diagnosis? Based on the calendar pattern. The calendar pattern is few days of symptoms which go off on their own, few weeks or 2 months of no symptoms, again few days of positional symptoms which go off on their own, again few months later, again it comes. We will also notice as vestibular professionals, maybe, I don't know, depending on for how many years we have been practicing. 15 years ago, when I would pick up a case of BPPV, it would be clear-cut BPPV. But now it is not like that. The reason is those days, most of these people already at the general practitioner level, they would have been tried a few anti-migraines, Temitil, something would have been given. And therefore all the migraine types, all those things would be filtered there only. What you get is actually the debris BPPVs. But now because of increased awareness, a lot of people are coming to us on this. So now we are getting the migraine positional vertigos, BPPVs provoking migraine, all kinds of things are coming to us. So 2 things are there. BPPV can trigger migraine can trigger BPPV, they can coexist therefore they can coexist. The next thing is, if you are not able to reposition somebody, and if the calendar pattern is such that they are having for 3-4 days or for 1 week, and then few weeks break, again few days up to a week, and then few break. In that case, don't feel lost. Start treatment as migraine.
Okay.
Okay, ma'am.
So by positional vertigo, you mean vestibular migraine, right, sir? The same term
Vestibular
for
migraine. I'm talking about vestibular migraine. Yes.
vertigo. Same. Okay.
Yes.
Sir, in bilateral vestibulopathy versus presbyvestibulopathy. So you mentioned in one takeaway message that in bilateral vestibulopathy, be steady in a static position. in pressed by vestibulopathy,
we
is
lost
it the
your-
patient is unsteady
we
in the
lost
steady
your-
position? So what is the...
Ma'am, we lost your audio in between. If you don't mind, can you repeat it again? We lost your audio in between. If you don't mind, can you repeat the question?
Can you hear me now?
Yeah.
So what is the one point of differentiation between bilateral vestibulopathy and pressed by vestibulopathy?
The one point of differentiation is the severity. That's all.
Okay.
That's all.
Okay. You had mentioned about the static one condition, a perfectly steady static condition, and in pressed by vestibulopathy will be steady in a static condition, something of that sort, or I got it wrong?
No, you can repeat that. Otherwise, you can probably just tell me the slide number or whatever.
Okay, I'll find out and I'll tell you. But it's generally the severity.
It is the severity. The most important thing is the severity. Okay. The severity of involvement. Bilateral vestibulopathy is almost complete labyrinthine loss.
Okay.
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 Yes. Any more questions? Otherwise, I'll go ahead with a huge agenda. I think I'll go ahead with the agenda for the day. Then if there are more questions, you can just keep them up and then I will answer them. Okay? Because I need to do 2 presentations now. Okay? Which I thought I could have recorded that instead of going over them for each batch 4 times over the weekend. But then these presentations are best if they are presented in front of you with a discussion. Okay? So, can you see my screen?
Yes, sir.
Okay. So, yeah. Okay. Fine. Non-vestibular symptoms in the patient presenting with to the balance clinic. Okay, so there are some things that we need to know. So one is syncope. So syncope by definition, just give me a minute, just improve. Syncope is a transient self-limited loss of consciousness due to acute global impairment of cerebral blood flow. So there are multiple words here which we have to know. One is global impairment of cerebral blood flow. So it is not because of an infarct somewhere. It is not because of a small clot somewhere in one particular place. No, it is complete impairment of cerebral blood flow, which is most of the time because of the reduced cardiac output. Okay. Onset is always rapid. The duration is very brief. Recovery is spontaneous and complete. Okay, recovery is spontaneous and complete. Okay, there is no residual neurological deficit at the end of the recovery to consciousness. Okay, but then at the same time, you have to remember other causes of transient loss of consciousness, that is seizures, vertebrobasilar ischemia, hypoxemia, and hypoglycemia. Okay. So one after the other we will deal. Okay. Okay. Which I thought I could have recorded that instead of going over them for each batch 4 times over the weekend. But then these presentations are best if they are presented in front of you with a discussion. Okay. So, can you see my screen?
Yes, sir.
Okay. So, yeah. Okay. Fine. Non-vestibular symptoms in the patient presenting with to the balance clinic. Okay, so there are some things that we need to know. So one is syncope. So syncope by definition, just give me a minute, just improve. Syncope is a transient self-limited loss of consciousness due to acute global impairment of cerebral blood flow. So there are multiple words here which we have to know. One is global impairment of cerebral blood flow. So it is not because of an infarct somewhere. It is not because of a small clot somewhere in one particular place. No, it is complete impairment of cerebral blood flow, which is most of the time because of the reduced cardiac output. Okay. Onset is always rapid. The duration is very brief. Recovery is spontaneous and complete. Okay, recovery is spontaneous and complete. Okay, there is no residual neurological deficit at the end of the recovery to consciousness. Okay, but then at the same time you have to remember other causes of transient loss of consciousness, that is seizures, vertebrobasilar ischemia, hypoxemia and hypoglycemia. Okay. So one after the other we will deal. First and foremost, how to differentiate between seizures and syncope. There is a nice paper, okay, historical criteria that distinguish syncope from seizures, American Journal. Okay. So this one goes by giving points. Okay, so they give points here. There are plus points and minus points. If the score is greater than or equal to 1 at the end of this, it is likely seizure. If it is less, then it is syncope. So all the things that go in favor of seizure will have positive points. All the points that go in favor of a syncope will have a negative points here. Okay, so that is how it is. Okay. So when the person wakes up with tongue bite or tongue cutting, it's a strong point in favor of a seizure. Person has a deja vu or a jamais-vu phenomenon. Hope all of us know what is a deja vu phenomenon or a jamais-vu phenomenon. Deja vu is like when the person is with you, the person feels that, okay, I have been in this situation before. Okay, that is deja vu phenomenon. Okay. Jamais-vu phenomenon is a person is there where he every day is, but it looks like new. Okay, a sense of unfamiliarity to things which is actually familiar with, to a situation is actually familiar with. Deja vu is being familiar, a sense of familiarity with something that is actually new. Okay. So these two things are there. These two are 1 point, not as strong as tongue bite, but still a point in favor of a seizure. Emotional stress associated with the loss of consciousness goes in favor of a seizure. That if somebody notices that there has been a head turning during a spell, then goes in favor of a seizure. Unusual posture, okay, this is posturing, limb movement or amnesia of spells. Person is under. All of these things go in favor of a seizure. This one, confusion after spell, post-ictal confusion goes in favor of a seizure. If of all these things, if you ask me, this tongue bite almost always goes in favor. It is very, this thing. Deja vu and jamais-vu is one thing that I have personally found helpful when talking to patients. And post-ictal confusion is one more thing that is really, really helpful. Posturing, there are some other points that it happens, when it happens, how much, all those things will come into play. Light-headed spells, sweating before the spell associated with prolonged sitting or standing, all these things go in favor of a syncope. Okay. So a person has been standing for a long time, after that the person had a fall. That goes in favor of a syncope. Standing in the queue, standing in the school, whatever. Okay. So person tells that I started sweating a lot and then I had this. Then it goes in favor of a syncope rather than a seizure. Okay. I felt a lightheadedness. Then it goes in favor of a syncope. Okay. So these are the things that will help us differentiate. And this presentation again has been shared with you. So you can take it from the portal. But I'm presenting it now, but you can use it for helping, when the patient comes. It is all that we need to just open this up when that patient comes 2 or 3 times. After that, the 4th, 5th patient, this becomes our second nature. We'll start asking this on our own. Then the next thing is syncope versus hypoglycemia. The thing that is not that much aware, the people are not that much aware of is hypoglycemia does not really cause falls. postural tone is preserved. That's a very beautiful point, and that came from actually syncope and hypoglycemia from this paper. Okay. The International Journal of Clinical Medicine in 2011. This is a very, very beautiful paper where they just asked doctors who have witnessed hypoglycemic episodes of their patients and then start describing, okay, what all happened. And when they took these descriptions and then started gaining information from each of those descriptions, what they found is postural tone is filled. They hardly told patients actually fell, patient. So that is not going to happen. And here is something that I want to share of myself. So that, okay, when a doctor has gone through something, then when they describe it will be of use. I was there in my PUC, that is in my 11th grade. So I was in the NCC. So on that, our NCC is on Saturday afternoons, post lunch. On that particular day, I had not had lunch and then I went to the NCC. What happens is, you know, they are little strict and whatever you make instead of attention, you make standard Ds, or standard Ds you make attention and you get a punishment. Okay, that is how things happen. So I did one such mistake and then I was told you take the gun, you put it on your shoulder and then you go all around the ground one round. So I went all around the ground. I had not had lunch and then I came. And then I stood. When I stood, the captain immediately knew that he saw me and then he told, oh, that guy, he's becoming pale. You ask him to go and sit. Okay, he's becoming pale. I could hear every word that he was telling and I was clear. But when my own eyes, it started becoming yellowish. And then I went down. They made me sit. I never fell. I could go. I could aram say sit. And then they gave me some water and all that. And in some time, I was okay. Okay. So postural tone is preserved. Number one point. Bystanders aware that something is wrong with subject, with the patient looking pale. So this is exactly what happened with me also. And that is what is written here. That is why I like this paper. It just coincides with the experience that I went through. Recovery is not immediate. When it comes to syncope, the recovery is almost immediate. The patient becomes recumbent. 2 minutes, the patient is fine. Whereas here, hypoglycemia, the recovery is slow. I have personally seen hypoglycemic episodes of a lot of people, including family members, and I know that it is not a dramatic. In a syncope, when you see somebody fallen on the road somewhere, you lift the legs and the patient is perfect after that. Whereas when it comes to hypoglycemia, they don't come to normal immediately. They take some time. In spite of you offering them sugar, you do whatever, it takes time. Recumbency does not lead to immediate recovery, unlike in syncope. And blood pressure does not fall, is similar to the patient's usual levels. These are the points. And if you just remember these things, lot of the time we will know like how it matters. And I am sure a lot of us have actually gone through both syncopal episodes, seen patients. We have also seen patients with hypoglycemic episodes. And the next time we come across this, we have enough points to tell, okay, this is hypoglycemia only, or this is syncope only. Patient is taking a long time to recover. Yeah, it is hypoglycemia. Patient has not lost postural tone. Patient looked pale. Even patient was becoming troubled. You could make out. These are the things that go in favor of hypoglycemia. Okay. Syncope versus vertebrobasilar TIS. In VBI, other symptoms of brainstem, cerebellum and occipital lobe are frequent accompaniments. Okay. So, in vertebrobasilar TIA, you start seeing other symptoms. Okay. Syncope is global loss, global reduction in the blood flow, whereas VBI is vertebrobasilar insufficiency, is posterior circulation insufficiency most of the time because of a TIA. Okay. And in VBI, again, the point here is this. Because it is, because it is only posterior circulation, so what will happen is, because it is only posterior circulation, where am I? Okay. Because it is only posterior circulation, cognitive symptoms like confusion is not there in vertebrobasilar TIS. They can tell what is going on through them. There is no confusion there. In syncopes, there can be intraictal, not postictal, but intraictal, there can be a confusion. Syncope versus orthostatic hypotension. Okay. This difference here is between syncope and orthostatic hypotension. Syncope is a transient. This is chronically impaired. Okay. So when you go through the definition of orthostatic hypotension, it is a sustained fall in blood pressure because of a orthostatic posture. Syncope is not like that. It is transient. After some time, the patient, next time patient gets up, they will not have the problem. Orthostatic is not like that. Orthostatic is a chronically impaired cardiovascular homeostatic imbalance, which means every day they will have. Syncope will not happen every day. Okay, every moment orthostatic hypotension starts showing up. Whereas syncope is not like that. It happens once in a while. Syncope that requires hospitalization are syncopes that occur in a recumbent posture. If somebody tells, I was lying down and at that time I lost consciousness, okay, or somebody lost consciousness when they were actually doing exercise, then it should not be taken as a simple case of a syncope, or where you see the general syncopes without underlying cardiac cause, where because of emotional stress or because of prolonged standing people fall. It is not like that. If somebody really has a syncope in a recumbent posture, or somebody has a syncope while doing exercise, then more likely that it is associated with an underlying structural cardiac problem, and therefore that person structural or a rhythm problem, and that person needs evaluation in the hospital. And also, if it is associated with chest pain or persistent bradycardia, okay, persistent bradycardia. There was one time in an airport and I saw a lady having a syncope. It was not associated with the immediate recovery, and the bradycardia was persistent. 10 minutes of observation and the bradycardia was not improving. Most likely something has happened. Okay, so that is related. That's an arrhythmia, probably a bradyarrhythmia, something like that. So that patient, I just made sure that she was picked up in an ambulance and sent for a further evaluation, because it is not simple syncope. Okay. Situational reflex syncope, cough syncope, wind instrument. See why I am presenting this situational reflex syncope is, there is a reflex syncope, and the moment you know what brought it about, you know what exactly is the cause. Okay, the moment it came, you know what exactly caused it. So there is cough syncope, wind instrument player syncope, weightlifter syncope, sneeze syncope, post-micturition syncope, swallow syncope, defecation syncope, carotid sinus hypersensitivity, ocular pressing syncope. All of these things, you reach the diagnosis just from the history, from the story. Somebody tells that he is losing consciousness, falling after defecation syncope, after micturition syncope, after having a cough, that's a cough syncope. So the very history will tell us the diagnosis. If somebody has a syncope because of a heart problem which causes bradycardia or nasystole, then it has a specific name that is called as Stokes-Adams attack. Then the next important point that I wanted to cover in the non-vestibular things is something called as a coat hanger headache. And this is one question that I keep asking a lot of patients who come with a chronic unsteadiness. Okay. This is neck pain in the suboccipital, posterior cervical and the shoulder region. Okay. What is this? Together, suboccipital, posterior cervical and shoulder region, all the 2-3 together, what they constitute. When you hang a coat, that hanger, which area of the coat does that the hanger take? Okay, that particular area. So person will tell in the suboccipital region, on the back of the neck and the upper shoulders. Okay, that area patient will tell pain. This is caused by neck muscle ischemia, and it is, you can almost be sure this particular person has a diagnosis of orthostatic hypotension. And this is something that I keep coming across again and again in the clinical practice. Coat hanger headache is something that I keep coming across, and most of the time the diagnosis turns out to be orthostatic hypotension. Cataplexy is another non-vestibular symptom that I wanted all of us to know. So what exactly happens in cataplexy? This is a fall. Cataplexy is a fall. This is a fall with retained consciousness. I hope all of you remember when we made the discussion of fall with retained consciousness, the other diagnosis that I was telling was a balance-related fall. Is that right? Balance-related fall. Whereas here, it is again retained consciousness, but unlike in balance-related fall, here it is because of a loss of muscle tone. The patient has retained consciousness, But here, the problem is loss of muscle tone. The muscles refuse to listen to the person. Nowadays, what is happening? Lot of people come to us with CCTV videos of their fall. And if the CCTV video of their fall reveals that the patient has not lost consciousness, and the video tells somehow the patient seems to be struggling to keep their muscles under their control, make their muscles work the way they want. If you get that feel, the diagnosis is cataplexy. Triggered by strong emotions like anger and laughter. Okay, so this is what happens. Okay, there's something called as a negative triggers also in some patients that is more associated with tumors in the brain. In that, it is crying which will cause this kind of cataplexy attacks. Whereas in the usual cataplexy where there is no structural problem, it is anger and laughter. Completely preserved consciousness. See, consciousness, muscle tone, abrupt. Duration 30 seconds to 2 minutes is what is told. But every cataplexy attack that I have seen so far, by the time every cataplexy attack that I have seen so far, if the second clock, by the time the second clock makes one full circle of the clock, by then the patient has completely recovered. Okay, this 2 minutes is an upper range, but most of the time in less than 1 minute, the person has completely recovered in cases of cataplexy. And in cataplexy, there is no premonitory symptoms, absolutely no premonitory symptoms, unlike in syncopes, unlike in seizures, where there can be premonitory symptoms. The other symptom, non-vestibular symptom that we should note is something called as a gait freezing. This is seen in Parkinsonism and Parkinsonian disorders. So, if the person comes with a history of gait freezing, this single point will lead us to make that neurological consultation to tell that you have to take the opinion of a neurologist. And that is this thing called as a gait freezing. This is brief episodic absence of forward progression of the feet despite intention to walk. There is this one lady who I have the opportunity of, she comes, the moment she comes near the doorway, okay, she cannot move further. She just freezes there. She cannot move forward. This is exactly what is written. Narrow doorway or crowd. If they see a crowd of people, I have not come across a crowd so far in history, but then there is a patient who, the moment she approaches the door, she cannot move forward. So, brief episodic absence of forward progression despite intention to walk. I want to go, but somehow I am not moving forward. This is called as a gait freezing, and this one goes in favor of Parkinson's and other Parkinsonian disorders like PSP, MSA. This is progressive supranuclear palsy. This is multisystem atrophy and corticobasal degeneration. Okay. Then slipping clutch syndrome. This is okay. Something called as a gait initiation failure. This is seen in frontal gait disorders. Okay. What are those? Cerebral small vessel disease, normal pressure hydrocephalus, mass lesions in the frontal lobe, neurodegenerative dementias. Okay. So any of these things can cause this slipping clutch syndrome or gait ignition failure. You know what is this? When we first started learning how to drive the car, or when we first started learning how to drive the bike, you know, somehow it doesn't move forward. Okay, suddenly the engine is there, you rev the accelerometer, and then you want to slowly leave the clutch. Suddenly it slips and then it goes off. So how many times it used to happen when we first began learning how to drive. Okay, so this is what happens. Okay, so gating can make, which means they cannot move forward. They cannot move forward. They try to move, somehow it hits him. But you ask them to sit and move the legs. What is needed, the kind of leg movement that was needed to walk, they are able to perfectly make it in the lying down position. They are able to make it in the sitting position. But you ask them, now get up and walk, they cannot walk. Okay, so this is the slipping clutch syndrome, which again is seen in, so this is also called as a lower body Parkinsonism. Though the name is lower body Parkinsonism, it is nothing to do with Parkinsonism. So it is seen in frontal gait disorders. Retropulsions, okay, among all the pulsions, okay, Parkinsonism is one thing which is known to cause retropulsions, okay. Again, difficult Okay. So the person, when you ask them to turn, they do en-bloc turning. En-bloc turning means when you ask them to twist their upper body to right, twist their upper body to left, all of us are able to do it. But ask them to turn right only with the body, they cannot. They'll have to do with the entire body. They have to do. So this is another feature of Parkinsonism. Lateral instability is a feature of cerebellar gait ataxia. You saw retropulsion, clear-cut directional pulsion to the backwards is Parkinsonism, whereas instability, side-to-side instability is seen in cerebellar gait ataxia. Truncal sway in a narrow base, this is a tandem stance. If you make narrow base or tandem stance, this is supposed to be or. Okay. So if you ask them to keep their feet close together, the feet together, or if the feet, 1 feet front and 1 feet behind. So this is tandem and this is narrow based. Okay, so if you ask them, then you can see the trunk, there is a truncal sway. Okay, this again the sway is right left. Okay, lateral, but it is not very huge. Okay, somebody gives a lot of hip girdle sway. Okay, lot of sway in the mid portion. Okay, the hip girdle right left. It is saying if you ask them to stand, then that goes in. Okay, I mean pelvic sway. It goes in favor of a hip girdle weakness. Okay. Steppage gait is seen in distal muscle weakness where they'll try to lift the legs up. Okay, they will try to lift the legs up. Okay, because peripheral neuropathy, distal muscle weakness, there is something like a foot drop. So to keep the foot clear of the ground, so they will try to lift it higher than what is usually done by other people. So this will cause a steppage gait, and this is going in favor of this. Then the next important point, which is very common in the vestibular clinic, is something called as a aphasia person. This person, odd gyrations of posture with wastage of muscle energy. You will see this, I've demonstrated, one of the lectures in the physical examination covers this one. The patient will not fall, but upper body does a lot of movement. Apparently, the person looks very, very unstable, but the person does not fall. Okay. Odd gyration of posture with wastage of muscle energy. So much of muscle energy they are wasting only in trying to maintain posture. They are shaking so much, but they wouldn't fall. Okay. Appear superficially unsteady, but when you actually see the extent to which they are moving around yet not falling, you will know, to move so much and yet not fall needs a better muscle control, better postural control than a person who would not move so much. So which goes against there is underlying deficit. So that is again seen in functional gait disorders. Okay, this is again very, very common in the vestibular clinic. You ask people and they start become very, 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 very unsteady. Okay, unstable. But then you know that this amount of instability needs more postural control than a person who is standing silently. Then tremors is one more non-vestibular symptom that we need to know. Okay, please excuse that there is no flow here, because I'm clubbing all the non-vestibular symptoms that a vestibular practitioner need to know, so I'm putting them together. So resting tremor is seen in Parkinsonism. Okay, when the person is keeping the hand at rest, it is shaking. Postural tremor can be seen in physiological, in anxiety. Okay, just benign essential tremor, which is absolutely okay, as the name suggests, a benign disorder. In case of Wilson's disease and also in case of cerebellar problems, you can see postural tremors. So what is the difference between resting tremor? You ask the person to just rest their hand on their lap, and still you can see a pin rolling or the shaking of their hands. This is Parkinsonism. But postural tremor is one. At rest it is not there. You ask the person to stretch their hands. Only then the tremor starts showing up. This becomes a posture tremor. Intention tremor is a cerebellar. Okay, intention. Okay. Only when somebody tries to do something, then they get a shake, then it is clearly cerebellar etiology. Okay. So these are the non-vestibular symptoms that we needed to know. This presentation is there shared on the learning platform. So I hope you listen, so you can just go through the presentation once more so that all these things are committed. Okay. Next thing I want to cover, post this presentation, again I will take questions from you. Okay. So I will start this thing. See, what happened is, according to me, this is one of the seminal papers that got published on 1st June 2016. There used to be lots and lots of different approaches that were told. Okay. There used to be a paper called Triggers and Timings. Okay. To help people reach a diagnosis of what exactly is the cause. Now, this people, Floris Weitz, okay, he is from Antwerp University. I met him. Okay. This group has come up with a very, very nice thing. It is SOSTONE. It is an acronym. And if you go by this, you will capture lots of points that are needed to reach a diagnosis. Okay, lots and lots of points that are needed to reach a diagnosis. And in some situations, they can be really, really revealing or making that difference. Okay, so what exactly is this? Is a SOSTONE is an acronym. S stands for symptoms. What exactly are the patient's symptoms? The things that are covered here, again, vertigo and spinning, which you saw in the Barney Society. Postural instability is there. Lightheadedness or dizziness is there. So, sensations of linear tilts or tilts of perceived vertical. Okay. Lateropulsion, oscillopsia. So, these are the symptoms that are covered. And each of those symptoms, they give the diagnosis which each of those symptoms can be seen. So vertigo and spinning can be seen in a lot of vestibular conditions like vestibular neuritis, benign paroxysmal positional vertigo, dehiscence, Meniere's disease, whatever it is. When it comes to postural instability, the set of diagnosis becomes different. See, vertigo or spinning is not going to be, postural instability is not going to be caused by the same conditions which cause this one. Okay. So postural instability is mainly for bilateral vestibulopathy or some other conditions like cerebellar ataxia or polyneuropathy. So like that, this is expanded. Again, this paper has been shared with you, so you can go through that. There is no need to take any notes right now. You just listen to this to just get a feel of what this paper is trying to do. So lightheadedness and dizziness goes in favor of like pre-syncope, phobic, panic attacks. Okay, so these kind of things. Tilt sensations always suggest some kind of a otolith dysfunction either in the periphery or in the central pathways. So here, when he used the term drop attacks, Barney Society's symptomatology was not yet released. So possibly this continues to be used. Okay. This is Tumarkin's otolithic crisis. Okay. But keep in mind vestibular paroxysmia, vestibular migraine or brainstem stroke is what is written here. Okay. So that is why vestibular or balance related falls, we have a differential diagnosis in balance related falls. One is Tumarkin's crisis as seen in Meniere's disease. We also have vestibular paroxysmia, vestibular migraine and BPPV as one of the differential diagnoses. Okay. You add brainstem stroke to this. That's all. If at all, brainstem stroke versus the other conditions, there is a nice differentiating point that I want to tell now. That differentiating point is found fallen. If somebody found the person fallen, that goes in favor of a brainstem stroke. Versus the other differential diagnosis, paroxysmia, vestibular migraine, Tumarkin's otolithic crisis of Meniere's disease and BPPV related falls. All the other things, the person can get up on their own. After the fall, they can get up on their own. They are not waiting for help to arrive to make them get up. Whereas in a person with a brainstem stroke, they would be waiting for help to arrive for them to get up. That is found fallen. Found fallen goes in favor of a stroke. Okay? Then how often? So in the SOSTONE, S stood for symptoms. Second is, okay, single attack goes in favor of labyrinthitis, vestibular neuritis, like this. Okay, this is the key point, a single attack or multiple attacks. Okay, so like that. Okay, but if somebody has multiple attacks, then the differential diagnosis goes in favor of vestibular migraine, Meniere's disease, episodic ataxias, these things. So see the differential diagnosis, how it shifts between single attack versus multiple attacks. Okay. So that is how things go. How often? Okay. How often do they come? Something that comes every day, morning, when they get up again, when they lie down, every day, PPPV. So like that. Every time they are exposed to a certain symptom, certain like loud noise or whatever, they go in favor of a third labyrinthine. So how often it comes again is a very important point. Then the next question is sins. And the sins is a little deep thing. It doesn't only talk about the date. It is not about since when we say it is not about a week, 1 month, 1 year, not just that. It also tells after what. You're all with me? Hello?
Yes,
Make
sir.
one noise. Yeah.
Yes, sir. Yes, sir.
Okay.
Yes, sir. Yes.
Okay. Great. Thank you. So it is not just since when, it is after what happened. So after what happened is a very important thing. A viral fever after that vertigo, vestibular neuritis. Okay. Then previous vestibular neuritis, now having BPPV. Okay. Previously the patient had this. Person tells, I had a knee surgery, I was in the hospital, or I had a hip replacement, then I had a shoulder surgery, then patient in the hospital. So post-hospitalization, post-immobilization takes the diagnosis in favor of BPPV. Typically known to occur after immobilizations. Okay. Lot of immobilizations lead to this particular thing. Okay. One episode of actual vertigo, long-standing unsteadiness. It all began with a real bad episode of vertigo, triple PD. Certain medications. Somebody tells, I was admitted in the hospital with vomitings, okay, fever and vomitings. After that, the patient becomes unsteady. Then it goes in favor of probably thiamine deficiency, okay, acute thiamine deficiency, which is provoked by vomiting sensation. By vomiting attacks. Like this, what happened and after this becomes very important in after what? After a surgery, somebody tells. Okay, maybe perilimb fistula. So like that, after head trauma. Somebody went, okay, there was a fight on the street, and after that, the patient has started developing oversensitivity to pressure and oversensitivity to sounds, superior canal dehiscence. Like that, what happened, the specific event is also going to give us the diagnosis in a lot of conditions. Somebody goes and tells, I went to the saloon, and then they did this neck release of the things. They do in the saloons lot of neck manipulation and all they do. They try to remove cut sound and then they feel good. After that, the patient starts feeling dizzy. Then it is a vertebral artery dissection. So like that, what happened and after that will tell us the diagnosis. Then what exactly is the trigger? What brings about the attack for you? Person tells, when I bend forward, when I look up, when I roll in bed right and left, this is all goes in favor of a benign paroxysmal positional vertigo, BPPV. Somebody tells, when I am sitting in the chair and then I get up from sitting position to standing position, this goes in favor of orthostatic hypotension, because here head position in relation to gravity has not changed and still the patient is having symptoms. Goes in favor of this. Somebody tells, I sit here, or you can make the person sit. Just is the trunk, whatever. Head bend forward, head bend upwards is not causing symptoms. Whereas if I stoop my entire body downwards and then I suddenly get up, then I have a problem. Goes in favor of a early orthostatic hypotension. So these are the things. What exactly does it trigger? Which trigger will cause? Somebody will come and tell, sitting up is causing problems. Going back makes me feel better. Which means from lying down posture on the cot, sitting up is a problem or standing up is a problem. This causes problem. Whereas when I go back here, I don't have any symptoms. Goes in favor of orthostatic hypotension. Whereas in a BPPV, both coming up and going down will cause problems. So like this, what particular trigger will cause? Okay, there are some not so immediate triggers, like person has missed sleep for a few days. Then the person gets then goes in favor of a vestibular migraine. So like that, what is the trigger? There are multiple triggers that are possible. Okay, there are movement related triggers, environmental triggers. Okay, so each of the trigger will help you. Okay, otology means we need to ask the history related to the other otological symptoms. If there is a hearing loss and vertigo, then it goes in favor of a what is called labyrinthine deficiency, and this labyrinthine deficiency can be because of a labyrinthitis, or it can be because of a ICA stroke. It can be because of a ICA stroke. There are some points which are here where very, very beautiful. These are, if somebody has auditory symptoms and vertigo, almost always the anatomical localization is outside the brainstem. Okay, outside or before the brainstem. What it means is, from the ear, the nerve, up to brainstem but not including the brainstem. The reason here is, it is only in the inner ear, in the internal auditory canal, and in before the nerve actually enters the root entry zone into the, that is the only place where these two functions stay together. The moment they enter the brainstem, the vestibular pathway and the auditory pathway take separate routes. Therefore, it is unlikely both of them are there together in a person in a brainstem related problem without any other associated. If it is really because of brainstem, then the person will have more features of brainstem. Okay, because they are really far away pathways. So if something else is, then they will also have a facial palsy, they will have something more like that. So almost always, if somebody tells that this thing, we can almost we can localize the problem to somewhere here. The moment you are localizing the problem to the inner ear does not mean that it is not ICA. That can be caused by ICA stroke. That's a different thing. Okay? You're all with me? Hello?
Yes, sir. Yes, sir.
Yeah, okay. Because one video froze and I thought we are not there. Okay, fine. Next thing is neurological symptoms. Okay, this dimension serves to rule out lesions of the central nervous system. Okay, so of course Hind's tool is there. We are going to teach something better than Hind's tool during the hands-on session. Okay. Now, in this also we have features which tell us, okay, whether somebody is having a migraine attack, okay, whether somebody is going through a stroke, okay, these are the things, okay. So, if somebody has associated headache, somebody has phonophobia, they go in favor of, okay, a vestibular migraine. Somebody comes with the diplopia, somebody comes with dysarthria, they go in favor of something vascular going on there. And nothing neurological means, okay, possibly we are looking at a purely peripheral etiology. Then evolution, how does it change? Vestibular neuritis almost always day 1 or day 2 is the worst. Day 1 or day 2 is the worst. After that, gradually the patient has to start becoming better. If the patient tells that no, with each passing day I am becoming worse, then it is not vestibular neuritis, or the patient has had situations where patient tells that they are worse, but on objective evaluation they are actually better off than day 1, on day 3, day 4. Okay. So, but if really it is worsening day after day, then it is not vestibular neuritis. There is something else going on. Okay. So like that. How does the symptoms evolve? Evolve is one very important thing to know. Then the duration. This duration is so important that there are papers only describing duration and telling just based on the duration I can tell you the diagnosis. There is another paper which talks about triggers and timings, in which timings or duration, based on duration they are able to tell what are the things. Like for example, if you know, Meniere's disease means, okay, it is always several minutes to hours. Okay. BPPV, it is always seconds to minutes. So like that, what exactly is the duration will tell us what exactly is the diagnosis. When you talk about a superior canal dehiscence, it is almost always the main attack lasts for a few seconds during or after the trigger. So it is like that. Okay. But of course, vestibular migraine is one thing that we have to remember. It can have duration, okay, which can have for seconds. But when it comes to seconds, you know that 5 minutes to 72 hours we tell about vestibular migraine, but then here we are talking about symptoms lasting only seconds. When you talk about only seconds, in a day it has to be accumulated, and that accumulated symptoms will cross 5 minutes is what is told. Though I have seen patients, it doesn't really happen. Okay. So all these things put together, you can make them into so stoned. This S-O-S-T-O-N-E-D. So stoned. And by seeing what are the triggers, what are all the things, we will have a discriminative power as to how to tell one condition from the other. We will be sharing this paper also. This presentation is shared. I think this paper is also shared. If it is not, I will just check and make sure that this paper is also shared. Shared. Okay. So that is there. You can go through things, take notes from that and make one. And one more thing is, there is an assignment for you this week. This week comes with an assignment. Okay. The assignment is, okay, I stop sharing. Okay. You have time till next Monday. Okay. So what we have done, you have to do two things. We have shared the papers of all the Barony Society classification. You have to take the example of the vestibular migraine presentation that I have made. You can see the way the vestibular migraine presentation is prepared. We first put the diagnostic criteria in one particular place, and then each term we take, read the paper, and we try to elaborate what each of those terms means. You notice that, my friends? Okay.
Yes, sir.
Now, there are two things. Two are mandatory, but one is no selection. You have to make a similar presentation for Meniere's disease. Number one. Similar presentation for Meniere's disease, each one of us. Second one, it is left to you. You can choose one of them which is not made into a presentation here. Any one, and you have to make one more presentation. This physical examination week is a lighter week. Okay. It is a lighter week because we are going to cover some of the physical examination techniques in the hands-on. And we are also going to cover a lot of physical examination, which in vestibular is actually benign paroxysmal positional vertigo, positional things in week 5. So because of that, this week is going to be a little lighter, and in that lighter week, please make sure that you have done this particular assignment. Next Monday, you will have to submit that assignment. You can just send it across to Abhishek, either on WhatsApp or email. We will compile all those things. Okay. All these things are part of the curriculum. So you have to take the example of the vestibular migraine, and you have to make a similar thing for Meniere's disease from the same paper. And one more condition of your choice. Whichever you choose, it is okay. You can choose PPPV, you can choose anything which we have not covered, maybe vestibular paroxysm, whatever, and then make a presentation. Okay. And maybe the best of things we'll pick up and then share with all of you so that everybody benefits, or one from each that you have made. Okay. And believe me, this is going to be a beautiful process of learning. This is going to be a beautiful process of learning because you will get an upper hand over Barony Society classification, which is key to our mastery of vestibular science. So will you all do that?
Yes.
Okay. So next Monday. Okay. Is that fine? Okay.
18th.
Yeah. Okay. Next Monday you will have to do one Meniere's. And what you make, you can use it for the presentations. From now onwards, I'm sure you'll be giving talks on vertigo in different places. So you can use the same presentations for giving talks. That is also going to be beneficial. Okay. You want to make it more colorful, add your personal experiences, absolutely no problem. But the minimum is the Barony Society criteria has to come out there. And if you want to add more things, you're absolutely allowed. The previous batch did a lot of assignments like this, and it was really, really learning. Okay. Is that fine? So any more questions, please do let me know. Dr. Now Navneet has not asked any question today, sir. Sir, you are muted.
Yes, sir.
Sir, any questions?
No, sir.
How was the week, sir? This week content was fine?
Yes, sir. Very nice.
Okay.
But content was much, so I'm going to many times.
Okay. You felt the content is too much or too little?
No, it was enough.
Okay. Enough. Okay. Fine. Sir, yeah.
Colleagues are very senior. Means when they ask the question, I'm just thinking why the questions are not coming in my mind.
Okay. They are asking wonderful questions. Yes, very nice.
Yeah.
Good, nice questions. Any more questions? Please do ask them.
This pre-syncope will always be followed by a full syncope attack.
No, need not. There are a lot of times pre-syncope does not lead to syncope. Yeah. Omkar.
Yes, sir. Sir, a little silly question, sir.
Yeah. There is no silly question. If it comes to the mind, it has to be clear.
Yeah. So many patients, especially Hindi-speaking patients, they come and say, "Sir, bhari lagta hai." Sir, bhari lagta hai. And we generally write it as light-headedness. So, what is exactly? Is it just a non-specific complaint, or is what importance should be given to that, sir, bhari lagta?
So it is.
And how can it be described?
Okay, it is like, again, when you talk about the symptoms, okay, there are some symptoms which have a discriminating value, as I said, whereas some other symptoms in themselves do not have a discriminating value, especially the sar bhari lagta hai. So in which case, I go by timing, triggers, curve, when you become better, these kind of things, to try to understand what exactly is bhari lagta hai. Because especially as ENT surgeons, we know a person with sinusitis also will have a feeling of head heaviness, and a person who is just recovered from a migraine headache also will have a little heavy head. And then there are patients whom we know are having BPPV, whom we know are having BP, because they come, we get the nystagmus, we treat them, and then they still have some bhari feeling. The moment you have treated, they tell, my head is free now. Okay, so these things are there. So most of the time the meaning comes from the associated symptoms. Okay, the symptoms that they come with, rather than the symptom itself.
Okay. Thank you so much, sir.
Thank you, sir. Any more questions, sir? No more questions?
Sir, what if patient had a fall and after which patient developed a vertigo-like symptoms but no nystagmus on examination?
Okay, see, when the person has a fall and comes to the vestibular clinic, for me the first consideration would be whether the fall itself was caused by the vestibular condition, number one. So that is one thing. In which case, again, I will pursue the fall-related diagnostic criteria, which is whether it was loss of consciousness, without loss of consciousness, whether it was only muscle tone loss, or there was an energy in the fall, If there is energy in the fall, I'll call it as balance related fall and then consider the 4 differential diagrams. But if the person we know has fallen for some other reason, road traffic accident or something like that, and then the person comes with the vestibular like things. One is, in our practice, post-trauma BPPV is very common. Post-trauma otolithic concussion is quite common. Okay, where they feel odd for long time. Post-trauma actually brain concussion is quite common. Okay. And then we all see whiplash associated dizziness. Okay. Where in the vehicle and all suddenly breaks, whatever happens, they have a whiplash and they have a long standing dizziness after that time. So these kind of things happen. So first question will be the moment you see vestibular symptoms and fall together, first and find out whether that fall was actually caused by the vestibular condition itself. If it is it was unrelated fall and then leading to vestibular symptoms, then possibility is a BPPV, and especially multi-canal BPPV is very common in a post-trauma situation. Or it can be inner ear concussion, or it can be even a brain concussion. Yes, Dr. Jain, I see you raised your hands. Ma'am, your mic is muted.
So going back to the previous slides, I missed asking you this question about the nystagmus and superior semicircular canal dehiscence. Mm-hmm. You had mentioned that you have to look in the direction of the canal to be tested to get a more vertical response. So
wonderful. Nice question.
Didn't understand that.
Nice question. See, now what happens when we looked at the horizontal canal? It was quite simple. Is that right? Because rightward movement, leftward eye movement, leftward movement, rightward eye movement. Yes, and that made sense. That made sense because head is moving horizontally, lateral canal is placed horizontally, eye moved horizontally, things were straightforward. When you look at the anterior canal, the superior canal, how is it placed? It is placed like this. Is that right?
Right,
is that right?
Yes, sir.
Which means the best stimulation of that anterior canal is not with this movement, it is not with this movement, it is with the movement happening at a diagonal. Is that right, ma'am?
Yes, sir.
Okay. So that is the stimulation. When that diagonal movement is happening, like this, okay, I will just exaggerate that diagonal to make it like side to side movement so that for ease of this thing, when it is happening like this, whatever. Okay. Now what is happening, or diagonal only is okay. When that is happening, if I am looking in this direction, okay, of the diagonal movement, my eyes have to move up and down to compensate, yes or no? Yeah. Is that right?
Yeah.
They have to move up and down to compensate. You are able to see my video?
Yes, sir.
Okay. Now you say same diagonal movement here I am doing, but instead of looking straight at the camera, I look in another direction and then do the same diagonal movement. Now my eyes have to actually roll to compensate. The point here is, if I am making a head movement like this up, the eyes have to move down. If I am making a head movement down, eyes have to move up when I am looking straight ahead. If I am looking 90 degrees to one side, when I make a head movement up, my eyes here have to roll. There is no point for the eyes looking in this particular direction to go up and down. They should roll to maintain the retinal stability. Is that right?
Okay.
Is that point clear?
Kind of, sir.
No, I'll repeat that. I'm looking straight. Okay. Okay. Just imagine that I am an alien. I have 2 front eyes. I have 2 side eyes. Okay. You imagine that I have 2 side eyes.
Yeah. Yes.
And 2 front eyes. When I make this head and up and down movement, my front eyes have to go up and down, correct?
Yes.
When I go up, eyes have to come down. When I go down, eyes have to go up. Is that right?
Right. Right.
For the same movement, the eyes that are placed laterally, how should they move? Does it make sense for them to move up and down?
To rotate.
They will have to rotate so that their retina will remain vertically oriented. Is that right?
Yes.
Similar thing happens to the eye in the anterior canal. Okay, this is the anterior canal.
Yes.
When I am looking in the direction of the orientation of the lateral anterior canal, it should move up and down.
Okay.
Is that right? When it is 90 degrees to it, it should roll for the same head movement. The same head movement. Is that right? So, and that is exactly what happens. That is exactly what happens also. And the beauty is you will start seeing in the 5th week, it is one single muscle is capable of taking care of this. It is the same muscle will take care of. In this position, it will bring up and down movement. In another position, it will bring that same eye muscle, extraocular muscle, will bring about a rotation. Okay, ma'am? You will see that in week 5. Just 2 more weeks, that's all.
Okay. So, sir, suppose if there is a right. Okay. So you will exactly tell us as to what kind of nystagmus in which head position would be seen in a suppose right-sided.
We will tell you that week. If we will make you draw diagrams, so much like you will start feeling. You will think that you've gone back to anatomy class. Okay.
Okay, sir.
Okay, ma'am. Thank you, ma'am.
Thank you.
Thank you, ma'am. Yes. I think Dr. Mukundan has raised his hands. Then Dr. Nikhil is raising his hands. Yes, Dr. Mukundan.
Sir, in this classification of Barney Society in vertigo, how do you differentiate between like visually induced vertigo, visually induced dizziness, and vestibulovisual symptoms, oscillopsia?
Okay. So when it comes to, I'll just open that presentation now. Okay. You're talking about, you're not able to see my screen, right?
No.
Okay.
Yes, sir.
So vertigo, dizziness, vestibulovisual and postural. Is that right?
Yes, sir.
So in vertigo and dizziness, again we have positional, head motion, sound induced, Valsalva induced, orthostatic and
other
trigger. That is trigger. Is that right?
Yes, sir.
So your question related to which of these things?
This one, sir. Visually triggered, this visually induced also. Triggered vertigo. It's there in that Baranese paper also.
Maybe you can share your screen and show me that.
I'll just.
You're talking about this one, visually induced vertigo and dizziness.
Yes, sir.
Okay. So the differentiation between?
This is an oscillopsia.
See, oscillopsia is a clear-cut this thing. That is not visually induced.
Okay.
Oscillopsia is when you see the scene moving and you can see both to and fro movement. Bidirectionally you can see. Okay, sir? That is oscillopsia. And that oscillopsia need not be triggered by vision, by visual stimulus. Visual induced vertigo is actually triggered by a visual stimulus, like a fast moving train in front of you. Even sometimes what happens is you are in front of a big lorry in the traffic signal and the lorry starts moving forward. You think you are going backwards. Yes. These are all visually induced vertigos. Okay, sir. And when we talk about, you're talking about this one, vestibular visual symptoms. These are different. Okay. So these are different. So we have visual lag, which is separate thing. Movement induced blur is a different. Oscillopsia is different. Visual tilt and external vertigo. Is that right, sir?
Okay.
Okay. So oscillopsia need not be triggered by something. Visually induced is actually triggered by a visual movement.
Okay. Okay, sir.
Okay, sir.
Okay, sir.
No more questions?
Sir, I
Nikhil had a question. Yes.
Sir, for that, in that video of that right hand rule of thumb.
Okay, you saw the video. Excellent. Thank you. Yeah.
So actually, I remembered about that when ma'am asked the question about that the vectors I understood about the direction and the vector the thumb is showing, but you said when you superimpose those vectors, you can then find out the final.
Absolutely.
And that superimposition, I didn't understand. Like,
see, what happens is you want to see what is the net action of simultaneously stimulating right lateral and left lateral canal. Okay, let us see what is going to happen. You are going to put warm caloric stimulation in the right lateral canal. You are going to put warm caloric stimulation in the left lateral. Both of them are stimulated. What happens to the eye you want to know. Is that right?
Yeah.
Okay, so now let us do what happens. Right lateral canal. Correct? You put the right hand thumb rule. Generally, which is the one that evokes the right lateral canal is this head movement. Is that right?
Yes.
So I have to place the head like this. Correct?
Yeah.
Place the hand like this. So the net vector will go downwards. You will get an arrow which is going downwards. Is that right?
Yeah.
When you talk about the left-sided movement, you put the hand like this. Is that right?
Yes.
And the vector goes up like the thumb. You get an arrow mark pointing upwards. So you get an arrow mark pointing downwards, you get a arrow mark pointing upwards. If you superimpose the two things and take the net of those things, down and up, both of them completely cancel one another, which means net result is nothing. Is that right?
Yes, sir.
Is that right? Correct, sir?
Yes, sir. Yes.
Okay. So now go for anterior canals. Right anterior canal. Okay, it is this stimulation which is going to make it. It is this stimulation which is going to provoke it. Left anterior canal. This stimulation is going to provoke it. Is that right? So I hold the right hand thumb like this. One arrow mark goes in this direction. Correct? I hold the right hand thumb for the other anterior canal like this. Okay? One arrow mark goes in this direction. So you have two arrow marks. One is going front like this, another is going like this. Is that right?
Yes.
Back leg. Two of them, one front to the left, another back to the left. Both of them together, if you superimpose them, you get one right in the center. Is that right? Okay. So I don't know whether my video is big enough. Okay. See, you just do that. For the right anterior canal, you saw this is the moment which is going to pass. So this is the vector direction, which is going facing left and front. Is that okay?
Yes, sir.
On your piece of paper, you can write left and front. Left anterior canal, if you do, it is going to be left and back. That vector will go left and back.
Back, yeah.
Okay, is that right? You take the two. You get a vector in the center. Correct? One is going diagonally front, one is going diagonally back, which means it is horizontally. One side. Is that? Yeah. Which means it will tell the head moving in this direction. Which means the eye should move up like this. As a compensation. You get a vector, we'll get a final vector which is horizontally pointing to the left.
Okay.
Which means it will tell that the head should turn. This head turning downwards will stimulate this anterior and this anterior. It simply, both of them are simultaneously equally stimulated, means it is equivalent to head going downwards. Is that right?
Okay.
The net result in the eye will be just opposite to this. Put the thing just opposite. This is what is going to come to the eye. What is that? Eyes will move upwards. Okay. So this is the advantage. Just look at this. The moment we start practicing this, it becomes so easy to visualize. Otherwise, you have to think this canal, this flow, this canal, this flow. You just put two arrow marks. Here in front of you, we could discuss what exactly is happening. Final vector, head movements like this, eye movements like this, matter close. Once we start using these mathematical notations, life will become super simple. Okay, sir? Okay. All that we need to do is like little bit of effort in the beginning. After that, this is going to be much more easy. You don't have to really imagine everything. You can reduce them to notations and get your results. Okay.